Hello, this is Annette Rebel, and in this podcast, we will talk about the blood component therapy. Specifically, we will talk about each component of blood component therapy, what's in them, and when to utilize them. This is the outline for this presentation. So for each different blood component, we'll talk about the composition, indication, and what specifically to consider when you use that component. Let's start with the PRBCs. When to give what, and here I have to refer to a different PowerPoint, different podcast when we talk about transfusion triggers to address what's the indication. However, let's talk about what different options we have when we have made the decision to give PRBCs. We have whole blood, and in a perfect world, that definitely would be a great way how to address bleeding. Because if we bleed whole blood, so we should give back whole blood, not specific components. However, administratively, because whole blood is much less stable than separated blood components, administratively, that's our biggest obstacle to use whole blood. We will talk about leukocyte reduction, when to use irradiated, washed, or frozen packed red blood cells. Let's first talk about leukoreduction. What it means is pre-storage, our donated blood is filtered in order to reduce the concentration of white blood cells to less than 5 millions per cc. That means it's a 99% reduction. So since filtration created a concentration of blood products, also it concentrated the concentration of white blood cells, and with that leukoreduction, it's less than 5 millions per cc. The leukoreduction has caused a reduction of occurrence of transfusion reactions, specifically related to white blood cell contamination. These transfusion reactions are for sure the febrile non-hemolytic transfusion reaction. It reduced the transmission of CMV because white blood cells have a nucleus, and the cytomegalovirus virus is contained in the nucleus. It's not contained in red blood cells, but it's in white blood cells. So therefore, by reducing white blood cells, it's not safe, but the transmission is reduced. The reduction of white blood cells also reduced the rate of alloimmunization to HLA components, since HLA is on the white blood cells. Patients who benefit from the reduction of alloimmunization pre-transplant, since a lot of your tissue matching is due to your HLA composition, so less HLA antibodies, better matching for transplant, therefore better outcome. Or if you have multiple transfusion needs, also we reduce the occurrence of atypical antibodies. Per theory, but also in practice, not with large randomized clinical trials, but with good database workup, the reduction in white blood cell concentration also is reducing the occurrence of transfusion-related acute lung injury. At the University of Kentucky, using leukocyte-reduced packed red blood cells has become our standard. If you're not practicing at UK, you surely should consider for patients with a history of febrile non-hemolytic transfusion reaction, but it's not 100% effective to prevent the other transfusion-related complication linked to white blood cells, specifically graft versus host disease. That brings us to the next slide, irradiation. So since there's still a considerable amount of white blood cells present at the donated blood, even after leukocyte reduction, in people who have sensitivity to immunologically competent cells, the only way how to kill those is to irradiate it. What it means is before transfusion, directly before transfusion, the product is radiated with 2,500 grays to inactivate the lymphocytes. That applies to whole blood, PRBCs, and platelets. Not FFPs, because FFPs doesn't contain any cells. Takes about 10 minutes, and the reason why we're doing that is to prevent the host versus graft disease. Host versus graft disease means I'm infusing an immune competent cell, most the T lymphocyte, into an immune compromised host. So the immune competent cell will realize in the new environment that this is not home and will initiate an immune response and release interleukin 2, which is a very strong mediator, to other immune competent cells. So that T cell will induce an immune response against the host, the new host, and so therefore lead to a severe pulmonary, renal, and cardiac disease. It's a multi-system disease. The indications for irradiation are recipients of an allogenic bone marrow transplant, immunosuppressed patients, so therefore any kind of like B lymphoma, status post chemo, you surely could make a point for it, or if there's any congenital immune deficiencies, malignancies, for premature infants or in utero transfusions. Transfusion of blood relatives. Also here, you can have graft versus host disease in an immune competent host. Cases have been reported from transfusion of blood relatives, or when you have a very close genetic pool like an island, Japan, there's a higher occurrence of graft versus host disease in immune competent recipients. The theory here is that the donated cell does realize that it is not in its home environment, but the immune system of the host does not realize that this is a foreign cell, and that happens in close genetic communities. So if parents want to donate blood for the children, irradiation can be applied to decrease that risk for a transfusion reaction. Washed PRBCs is a process when pre-transfusion the component is put in several water baths and then spun off. The reason why we do that is to minimize the amount of plasma protein the recipient is going to be exposed to. It's a very labor-intense step, but it's definitely shown to be beneficial to reduce allergic anaphylaxis reactions towards your blood component. The indications therefore are patients with severe allergic reactions not responding to treatment with antihistamines, people with a history of immune A deficiency or haptoglobin deficiency, because if you transfuse a blood product containing hemoglobin A or haptoglobin, the first time you give a sensitization, but then the second time this patient receives a blood product, you have a high risk for an anaphylactic response towards that blood product. So immunoglobulin A deficiency, either use an immunoglobulin A deficient donor or use washed red blood cells. Frozen packed red blood cells is a process where instead of storing the donated blood product at 1 to 6 degrees Celsius for 35 to 42 days, pre-storage you add glycerol for cryopreservation. So antifreeze, you can therefore put those blood components into a much longer storage time We utilize that process for very rare blood types, or when you have as a crisis or catastrophe preparedness for strategic blood depots. If you have to go into the frozen storage, from call until you have those blood components available takes a lot longer than it does for regular blood products, up to 24 hours before that PRBC is available, because all that antifreeze has to be washed off. After the thawing process, the shelf life of this product is less than 24 hours, so if you have to utilize this, please make sure that you really are going to use that component. It's very painful if you then have to throw it away. So how do we know, after we make the decision that we want to go with blood component therapy, how much do we need to give? For packed blood cells, each unit has a volume between 200 to 350 cc's, and the target hematocrit in those products is 55 to 70% hematocrit. So therefore, normal blood volume average for 70 kilo patient, 1 unit of PRBCs should increase your hemoglobin level by 1 gram per deciliter, or increase your hematocrit by 3%. But surely that depends on the patient's blood volume, height and weight based, and we talked about this in our previous podcast, the hematocrit in your packed blood cells and the storage time of the PRBC. In pediatric patients, we use 8 to 10 cc's per kilo to increase the hemoglobin level by 3 grams per deciliter. To really be accurate with your calculations, I also include in the slide here the numbers for blood volume estimates. An adult female, 65 cc's per kilo, an adult male, 70 to 75 cc's per kilo, infants 80 cc's, full-term neonate 85 cc's, and premature neonate 95 cc's per kilo. To calculate your blood volume, because then you know how much to transfuse to get your hemoglobin level to a target. So after talking about PRBCs, let's talk about platelets. Platelets are prepared in several techniques. The oldest one, and the one we're most familiar with, is just by spinning. The donor blood is first split into PRBCs and plasma, and that first is the plasma-rich, platelet-rich plasma, so-called soft spin. And then to separate plasma from platelets, we do a hard spin, and the sediment contains the platelets. This process is relatively harsh, and you lose a lot of platelets just by the mechanical stress of centrifugation. So in the recent past, more sophisticated separation techniques have been developed. The most gentle one is apheresis, gives you the highest yield of platelet generation from donation. However, apheresis is a very time-consuming process. You have to have very compliant donors who are happy to lay there on a machine for 4 hours to get their platelets captured. We do have an issue in this country with people who are willing to donate blood products, so being there for 4 hours surely does not help with the recruitment. Platelets are stored not as cold as the other blood components, so 20 to 24 degrees Celsius, and they're constantly in motion because surely they're at highest risk for forming clots and therefore unusable. Before storage, they also go through a filtration process to decrease the amount of white blood cell contamination. Before storage, also by just pure microscopic examination, we make a determination of the quality of that blood product, and with pH as more acidic, as higher is our fear of bacterial contamination, which is our highest, biggest fear, worried about the platelets, because we can't keep them that cold, that they are getting contaminated by bacteria. We try to address this also by microscopic examination. We monitor glucose levels, and there's an automatic culture process 24 hours after collection to minimize that risk. It doesn't eliminate it, but to minimize it. So, what are indications for giving platelets? Traditionally, we had much higher thresholds for prophylactic platelet transfusions. Platelet count below 20,000 is the traditional threshold, but that has been challenged, and currently much lower thresholds have been accepted. Currently a trigger of around 10,000 appears reasonable, even less in patients with where there are no procedures planned, there's no indication of coagulopathy and spontaneous bleeding. For most surgical procedures, we accept platelet counts around 50,000 to be sufficient for hemostasis. In neurosurgical procedures, and that includes neuroaxial anesthesia, we like to have a platelet threshold above 100,000. However, I'm also expecting that here we are more lenient towards accepting lower numbers if a patient is stable at that. In massive transfusion protocols, please keep in mind that the ratio of platelets towards PRBCs and FFPs is not known. So we are here much more kept to monitoring our clinical situation, hopefully have TAG or RODEM monitoring available, where we get more an idea of in vivo assessment of coagulability. Patients who are on antiplatelet drugs, keep in mind, numbers look fine. However, due to irreversible or more reversible pharmacological interference, aspirin and Plavix, you might have to give platelets despite sufficient platelet count if the indication, meaning surgical procedure, calls for it, or spontaneous bleeding. So there's situations with exceptions to our transfusion trigger I mentioned in the previous slide. On cardiopulmonary bypass, the platelet reduction is due to hemodilution, and so therefore there's a transient platelet function impairment. You don't need to prophylactically transfuse platelets, only if a patient comes off pump after reversal of heparin, still refractory bleeding. Your thrombocytopenic purpura especially risks are neonates for intracranial hemorrhages. So your transfusion trigger is slightly higher in those patients, around 30,000. However, in that disease, TTP, there's a higher incidence of adverse reaction to platelet transfusions. Try to avoid unnecessary platelet transfusions because you are precipitating alloantibodies in transfusion reactions. Consider plasmapheresis to minimize the use of blood components. In heparin-induced thrombocytopenia, HIT, since this is based on your drop in platelet count is an indication of thrombus formation, avoid platelet transfusions. As more platelets you give, as more and more you put this patient at risk for thrombosis. In ITP is an autoimmune condition. It's caused by antibodies against several platelet surface antigens. More platelets you give, as more transfusion reactions you will have, and it sets you up for more thrombotic events. Only give platelets when you have serious bleeding concerns. So how much platelets to give? Depends a little bit on how your platelet has been, your platelet content has been generated. The pooled platelet concentrate is sufficient to decrease the amount of the bleeding risk in a normal adult sized patient. So 1 pooled platelet concentrate. 1 random donor platelet concentrate usually increases your platelet count by 5 to 10,000 in a normal sized patient who's not refractory to platelet administration. Apheresis generated platelet concentrates have a higher concentrated of platelets, so therefore it increases your platelet count higher, more to 30,000, 40,000 in an average sized patient. In pediatric patients, your doses need to be based on body weight. So 5 cc's per kilo is a increase by 5,000. In kilo, like above, in children with body weight higher than 8 kilos, you use a standard dose, 1 unit per 10 kilos. When do we have to worry about refractoriness to platelet transfusions? That means my platelet count is not as high as expected. So there can be non-immunologic factors. Patient has splenomegaly, so they have a higher spleen uptake. We also see this in advanced liver disease, higher splenic blood flow. Sepsis, you definitely have a resistance to platelets. And certain medications can cause it. Vancomycin and Zosyn being here at front, also inducing decreased production by bone marrow. But the biggest thing are immunological factors, meaning there are antibodies against platelets are present, so therefore marking them and therefore uptake by spleen and immune system. What can we do? The best thing is to prevent it. If you use leuco reduction steps, therefore less HLA antibodies, therefore less alloimmunization. Overall, restrictive use of blood components is the best prevention to not have to deal with that. And if you use platelets, try to be ABO compatible. You don't have to, but it definitely decreases the amount of alloimmunization. If you already have a recipient who is refractory to a platelet transfusion, if you match the HLA antigen status, you have less alloimmunization, therefore less uptake. In extreme stages, you also can go to a cross-matching step for platelets. Let's talk about FFPs, how they're prepared. As I said earlier, after donation, your donated blood is spun, centrifuged, and therefore separated between packed blood cells and platelet-rich plasma. You donate it a little bit further, that's how you get your platelets off, and the remaining part is a fresh frozen plasma. You gain about 150 to 400 cc's per blood component, depends a little bit on your hematocrit and how much volume you started out with. There's a heavy amount of anticoagulant added to this blood component. Citrate, most importantly, and the citrate load in FFP is 3 times higher than what you have in PRBCs. After collection, this component is frozen below minus 18 degrees within 8 hours after collection, and it can be stored for a relatively long time. FFP contains all coagulation factors, including the very labile factor 5 and factor 8, which are smaller amounts, and depending on your storage time and your preservation success. But these are the weak spots, factor 5 and factor 8. So therefore, you can treat a lot of isolated factor deficiencies with FFP, but you might need a lot than if you would use isolated factor supplementation. FFP does contain fibrinogen, but as a regular plasma concentrations around 180 milligrams per unit. FFP should be transfused ABO compatible. The rhesus status, you can use positive even in a negative patient, but you try to avoid it because of the sensitization of the recipient. So when do we give FFP? As I said, if you have a single factor, a coagulation factor deficiency, can, but you should really attempt to supplement individual factors if available. But for sure, if you have multiple factor deficiencies, like you have in severe bleeding trauma, DIC shock, this is your approach of choice. The same thing in vitamin K deficiency situations as pharmacologically, that's how warfarin works. FFP is the way how to reverse that warfarin effect. If you have surgical bleeding and inability for hemostasis, as it would be a delusional or consumptive coagulopathy, when you have antithrombin 3 deficiency, in pediatric patients, when they have hemorrhagic disease as a newborn, coagulopathy, or immune deficiency. There's certain situations which I want to point out to you when it comes to FFP use. First of all, FFP is not a volume replacement. Yes, it's a lot of volume, but it's not a volume replacement. When we try to address single factor deficiency, as it would be hemophilia A, B, or von Willebrand disease, there is some contained in FFP, but there are single factor products available. Prothrombin complex, or PCCs, are sometimes an alternative to FFPs with a lot of advantages. PCCs are enriched in prothrombin, factor 7, factor 9, 10, and a small amount of factor 8. So a majority of the vitamin K dependent coagulation factors are in the PCCs. For TTP, which as a pathophysiology, it's the inability of or deficiency of a cleaving enzyme, therefore the inability to cleave von Willebrand factor platelet interaction. It leads to an intravascular aggregation of that complex. Giving FFPs will address this cleavage enzyme deficiency. So the treatment for TTP would be a plasma exchange with FFP, 40 cc's per kilo, addition to steroids, chemotherapy, and splenectomy. FFP is the hallmark gold standard for reversal of vitamin K antagonists, that's warfarin. If I have a patient on warfarin who needs to be urgently reversed, going to the operating room, that's what we use, but realize it's a high volume replacement. It takes a lot of volume for FFP to reverse your INR. In PCC, because it's a lower volume, it's about like 150 cc's for an adult patient for reversal, and therefore I can perform that faster and as efficient. So we should consider that. If a patient has to go to the operating room in a less urgent situation, almost elective, it also is appropriate just to hold the warfarin and give vitamin K, PO or IV, depending on how quickly onset desired, can reverse warfarin action within 8 to 24 hours. So how much FFP do we have to give? Standard 10 cc's per kilo of FFP. Volume is recommended for an INR correction. Need to be PTT, an INR guided if your INR is excessive, meaning above 5. And the volume can be up to 20 cc's per kilo. So I start with 10 and then repeat and then take it from there. But if you have a 70 kilo patient, that means 700 cc's of a high protein concentrated solution. Tremendous volume effect if someone has signs that he might not be able to compensate for that increase in intravascular volume, as it would be diastolic dysfunction, CHF, etc., etc. FAP is not effective if you try to correct an INR which is only minimal elevated, and the need to do that really has been questioned. I know we see that clinically, unfortunately, but you have to keep in mind FFP has an INR between 1.3 to 1.8.5. It's guided by the citrate, which has been used for anticoagulation of this blood product. So the citrate content, as I pointed out, it's 3 times higher than what you have to deal with in a PRVC, and citrate metabolism depends on your liver function. So if you give FFP and you have clinical signs for not appropriate liver function, then you really have to monitor for signs of citrate toxicity, which is hypocalcemia. Let's talk about cryo. And when I think about cryo, I think about glue, because that's what it is. The way how we get cryoprecipitates, the preparation to get the step, is we have that plasma after centrifugation, the platelet enriched plasma. Then the platelets are taken off. Then I have FFP, then it's frozen, and the little foam on top, that's your cryoprecipitate. That's slowly thawed at 4 degrees and taken off. Cryoprecipitate is rich in factor 8, Van Willebrand factor, factor 13, fibronectin, and most importantly, fibrinogen. Instead of the 180 milligram per unit, here we have 800 milligram per unit. It's 4 to 5 times more than you find in FFP. It's stored at minus 20 degrees, also takes a lot of time to be thawed. We can just put it in a microwave, and has been used pretty shortly after it has been thawed. We try to have it ABO compatible to decrease the amount of alloimmunization, but it's not necessary. So when do we give cryo? Well, when you have a low fibrinogen level, documented low fibrinogen level, less than 100 milligram per deciliter, you have to assume coagulopathy based on the lack of availability of fibrinogen. Since cryoprecipitate is rich in Van Willebrand factor, also you can treat bleeding due to Van Willebrand disease if the patient is not responding to DDAVP or you don't have recombinant Van Willebrand factor available. You can treat hemophilia A with cryoprecipitate, but it's not your path of choice. Only is used if you don't have factor concentrate available, patient is bleeding. You also can consider here activated factor 7, that's an FDA approved use of Novo-7 severe bleeding due to hemophilia A and no factor concentrate available. In massive blood loss situation, sure coagulopathy, we're losing whole blood. If we don't supplement whole blood components, it can be cause of blood loss. Also consider consumptive coagulopathies, DIC fibrinolysis. As you hopefully remember some tag pictures, the reason why those patients are bleeding is because the clot is not persistent and fibrinogen gets eaten up, thrombus is generated but then not durable, so therefore is not not present anymore, and patient develops coagulopathy. Leading sign here is drop in fibrinogen level. So if supportive therapy or just waiting is not cannot be done because the patient has signs of active bleeding, supplement fibrinogen early, and that's done by using cryoprecipitates. How much to give? Usually start with 1 unit and then measure fibrinogen levels, best indicator of if you supplement, and clinical observation. Please contact me if there's any questions about the topics we have discussed. Thank you very much for your attention, and if you're inclined for further reading, here are a few references, and thank you very much.